Dr. Zubairi is a developmental pediatrician at Ron Joyce Children's Health Center and assistant professor in the Department of Pediatrics at McMaster University. His primary area of clinical work is with children with autism and psychopharmacology. Dr. Zubairi completed his Master of Education at the Ontario Institute for Studies in Education with a research focus on where culture matters in day-to-day clinical encounters and how simulations can promote critical reflective practice. Dr. Zubairi is a member of the McMaster Autism Research Team and sits on the executive for the section of Developmental Pediatrics at the Canadian Pediatric Society. He's also a board member with the SAAAC Autism Center. Please welcome Dr. Mohammed Zubairi.
Good morning. I hear a little bit more than that. Good morning. All right, make sure everybody's awake. I know some of us are on our cell phones. That's okay. I was on my cell phone too at one point. I just want to highlight a couple of things. In all fairness, I am a board member with SAAAC, and when they asked me to present and I agreed, I didn't think that I was going to be the first person up. So here I am. Either this is to your luck or to mine, I don't know, but I just love to share some thoughts with you guys around a topic that I'm particularly interested in, very well recognizing that there's lots of people in this audience that have a lot of experience, both clinically, personally, professionally, that can help inform this conversation. And so I just want to acknowledge that I do feel a big weight on my shoulders to be presenting initially, and recognizing that really if there's one message that I can leave you with today, it's a message that says that ensuring proper access is really about a combination of collaboration and trust. And I think, at the end of this conference, my hope is to continue to build on those collaborations, many of which I've had an opportunity to build through previous conferences, conversations, but at the same time recognizing that all the communities that are out there that we might be thinking about, including our own communities, there is a need for trust within that as we build those partnerships and relationships. So with that in mind, and my attempt to use this clicker, those are my disclosures. What I want to leave you with today is really a combination of a few things, and that at the end of this particular topic, we do have lots more questions that we want to try to answer than answers that I'm going to present to you. So this is really meant to be an opportunity for you to think about how you might conceptualize these issues and what it might mean when it comes to these issues related to screening and diagnostics as it pertains to the to autism spectrum disorder. The other piece that I want to highlight is that there is limited evidence or limited alignment when we think about how screening tools and diagnostic tools are developed and to the populations in which they might be administered. And this will start to make sense as we get through the talk. And then finally, the last 2 points are really about how do we think differently about assessment? How do we think differently about the frameworks that we might use when it comes to the knowledge that has already been developed and how that can be applied to emphasize childhood strength, ability, and functioning. And then finally, as I've briefly alluded to, is that when we think about this concept of best possible information, it really is stemming from the opportunities for best possible collaborations. And I really want you to sort of go home and think about that. I always present my takeaway points initially because this is the crux of what I'd like to make sure I'm sharing with you as somebody who's had a few days to think about this. So what's our context? Our context is that it's a really changing environment. The world in which we live in, due to a number of different trends, is evolving. And as a result of that, not only are our patients and clients, and so I might use those terms interchangeably, are evolving in terms of their experiences, but also what we as professionals bring or practitioners bring within that clinical field or in the sector field. And as a result of that, what we've got is a situation where inevitably everybody in this room is going to have an opportunity to interact with somebody who comes with diverse cultural experience. And that may involve their histories, their values, their beliefs, their individual trajectories. And not only does that hold true for the individuals that we're interacting with, but also for us as folks that are in the sector, and for folks that have the opportunity to provide social services, healthcare services, education services. So there's this really interesting mix that's happening that does raise some interesting questions. I just want to briefly chat a little bit about, skip there. share a little bit about my context, which is as a developmental pediatrician, and I'm generalizing here a little bit, but the most common question as a subspecialty physician within the field of pediatrics that I might get is this question of query autism as a referral question, either coming through a family doctor or coming through a pediatrician, but in many times suggested by a therapist, right? Somebody who's had an opportunity to engage with a child in various capacities, either through speech and language services, occupational services, and it raises a broader question. Again, I'm not going to try to answer, but really, under whom does the sort of the parameters of making a diagnosis rest, right? Who can make that diagnosis? Who can suggest that diagnosis? And how explicit or implicit do we have to be as part of that conversation? And then that leads to the next piece, which is how do you arrive at a diagnosis? What does the diagnosis mean? Who are the folks that make it to that stage to begin with, right? And so when we're thinking about access, I think we need to think about all those elements as it pertains to the diagnostic process. Obviously, the goal of today's talk is not to talk about the diagnostic process itself. There's lots of people in this room who've thought a lot about this in various capacities, but I just want to highlight that that's an important consideration. And ultimately, as part of that consideration, we think a little bit about, I think a little bit more about than little, around criteria and assessment tools. And that's what we're going to focus on in a few slides. The other piece to be cognizant of, and again, I'm sure many of you are well aware of this, is just the reality of trying to tease out diagnoses with increasing age, right? I think that that is a challenge at a younger age, but it becomes even more complex as children age. And for us to be thinking about various diagnostic categories, thinking about the conceptualization of each of these diagnostic categories and the interplay with them is a real question and challenge that we have to acknowledge, particularly because when a kid's 12 or 13 or 14 and is coming to my attention, that conversation is going to look differently than if a family is being referred when they're 2 or 3. There's certainly shared elements there, but the conversations can take a slightly different angle. And also recognizing, and I'm very conscious of this, is that there are newer conversations, there are newer conversations that are happening, and parents are coming with understandings of conversations that are shifting, and it's our responsibility as diagnosticians, as clinicians, as folks in the industry to be aware that families are coming to information to channels that may not be the typical traditional channels, and that can help inform or not, depending on the context, a whole other set of conversations and recognitions and challenges in our ability to come to some sort of shared understanding. So I have spent a lot of my other time, when I think about it, trying to think about the alignment that exists between what we as professionals, particularly developmental pediatricians like myself, are expected to do when it comes to engaging with families with various diverse backgrounds, experiences, and cultures, and what's happening in the front lines. And so there are expectations that come down from policy documents, legislation, and so on and so forth, college requirements, and then there's what's happening clinically. The goal of today is not to talk about that, but I just want to highlight that when we think about these intersecting circles, we may think about individual worlds or arenas in which people exist, and then there's the in-between space. And that point that I made earlier on collaboration and thinking about how do we bridge those communities together between whatever sector you might be involved in and the patients, families, clients that you're working with, and what does it mean from a broader understanding, from a collaborative perspective, because I do think there's a space there that we need to consider. With a little bit of bias, I think that SAAAC does a good job at it, but I think that that's an important consideration for us from a recognition that there's a lot that we don't know, particularly about that space in between, and how that can help intersect between the other elements that we're considering. So, just thinking out loud with you guys at this moment is that what is all of that complexity, the new conversations, the varied layers, the recognition that there's multiple diagnoses with increasing age, what does all that complexity mean in terms of what is the best possible information that we're trying to gather about a particular family, about a particular child or youth and their family in a big picture setting? And at the same time recognizing that our language is evolving. For those of you that were at INSAR this year, one of the the president gave a brief overview of just the changing language even within organizations, and our appreciation that when we think about disorder or disease or disability and identity, there's lots of considerations that come with us. And I pay particular attention to that from the perspective of a family, right? We may have a shared understanding of what some of these terms may mean. We may not, but then how does that information get communicated to the families that we're seeing? And then ultimately, how does our language, what we say and do clinically, or in our other sectors, permit or not what stories families can tell, what stories other professionals can tell. And that the nature of those stories might look differently. If you're meeting me clinically and I'm taking a history, that might look differently than if you're doing an intake assessment in one of the community organizations. But I'd like us to think about, from an access perspective, what information are we letting families share with us? Are there parameters that limit the ability to gather some types of information over other? This is for reflection. I don't have an answer to that question. You're all probably wondering, when is he going to give answers, right? So for the perspective of ASD, just sort of narrowing the focus right now, when we know from the literature that individuals that come from culturally and linguistic diverse backgrounds can be and often are misdiagnosed later, and there's a higher occurrence of misdiagnoses. So, can be later diagnosed and higher occurrence of misdiagnoses. And we know right now, within the context of a number of jurisdictions, that population-wide ASD screening is not recommended, although it is considered in some areas. And then obviously our consideration of recognition of ASD at an early stage has implications for early intervention. So that's often that connecting point when we think about, we can identify it, but then what does that mean in terms of supporting that particular child and family in their journey through that early identification process. And what gets really interesting from a clinician's perspective, but also just sort of broader considerations, is the reality that there are a whole number of cultural differences that exist based on what we define as social norms or socially appropriate behavior within the context of different domain categories, whether that be play, whether that be display of emotion, something, and the extent to which children may play with different action figures, toy dolls, and so on and so forth. So this may not come as a surprise to you, but it is something that's there, and how do we attune ourselves to that particular consideration? And realizing that cultural linguistic competence in terms of skill set and ability happens within families. And I want you to remember that piece a little bit, because many times our questionnaires and our assessment tools are designed to what the kid is doing. But recognizing that by ignoring what that family is doing, we may actually be missing out an important piece as it relates to our shared understanding of that kid within their environment. So I'd really emphasize that. Ultimately, when we think about the DSM criteria, there aren't any specific criteria that relate to cultural variation, language historically was considered not in the latest iteration, but not from a cultural perspective. So there are some nuances there. And behaviors that are socially appropriate and reinforced within one community may actually be considered a risk factor or a flag for autism from the perspective of the more dominant kind of viewpoints. And I'll get into that in a second. So some of the other work that I've done, just to sort of take a tangent briefly, is that many of our historic, and I presented on this in our last conference, where many of our assumptions are grounded within the biomedical model. And this is an important recognition and realization, because so much of our energy is focused on diagnosis, right? Let's come to a diagnosis, and then something's going to happen as a result of that. But because of that, a lot of our training and our understanding of what we're supposed to be doing clinically puts all of our energy there. And that sometimes misses the broader consideration of cultural elements and a number of different factors that can play a role in, again, developing that understanding of that particular child and family and youth if they present at a later age. And then there's conversational things that can happen as a result of that. We're trying to have the family buy into our diagnosis. We're trying to set specific expectations of a clinical educational encounter, and then families push back. So you can see how that is a very, confrontational model. And this is what frontline clinicians will say, right? Like, this is based on research that I've done as part of my various contexts. But then how do we bridge that conversation so that it doesn't sound like we're trying to constantly convince somebody that they've got something, and then use that as our starting point, because you can imagine where that might go. The other piece is then, as we switch gears, is just as an important consideration is our recognition that there are differences in screening tools and diagnostic tools. At the end of the day, currently ASD is still considered a clinical diagnosis, right? So there's a checklist within the DSM-5 as per the sort of standards right now. But there are a number of tools where level 1 tools are essentially designed to think about any children, regardless of their risk level, right? So at a very broad population level. Whereas a level 2 screener is designed to think about considerations where there have been some concern that's been raised either by a parent or a provider, or if there's some risk factors like, sort of preterm birth. The examples can go on. But that's what the differentiation is between a level 1 and a level 2 screener. When we think about diagnostic tools, now we're thinking specifically tools that are looking at the core symptomatology of ASD and then trying to identify and differentiate it from another developmental disorder. In that complexity slide, excuse me, that I presented to you earlier on, that can get a little bit challenging. So when we think about all of our current tools, the majority of them have been developed in specific Western English-speaking industrialized contexts. That's just the reality. And that has certain implications when we think about the test itself or the tool itself and what influences can play a role on there, particularly cultural influences, including those on test performance, thinking about the actual content and the familiarity of the process of being tested, right, is a cultural consideration, effects of formal education and the interpretation of results, the content, as I've alluded to, and then the use of pictures. All of these can be grounded in cultural variation, potentially. And to the point that I made earlier, which is there's a lot of movement of people happening. So it's not that we develop a test here and we want to implement it in another part of the world. People are moving so quickly now that the likelihood of you interacting with somebody that may have had a different experience when it comes to tools is higher. So we have to recognize that in terms of considering what tools we're using. And if I can actually highlight, if you haven't already, the one great paper to read is that by Norbury and Sparks from 2013. It's 6 years old, and it really was sort of a seminal paper when it comes to thinking about issues related to the nuances as they pertain to cultural understanding. So there's another paper, actually I'll sidetrack just for 1 second. After I had presented the title of this particular talk, coincidentally, Dr. Penner and her group from U of T had organized a workshop on addressing sociocultural elements and factors in terms of our research directions when it comes to working with individuals on the autism spectrum. And I think one of the things that we had talked about was this next paper that I want to just highlight by Bryn Harris et al. From 2014. And what they actually did, which was really interesting, was that they created internally, again, this is 5 years old, right? So we want to think about how things have changed even in the last 5 years. But they created a set of criteria to look at specifically how tests that are currently in practice have actually been, whether they're meeting certain of these in terms of their cultural relevance, considerations for cultural adaptations and changes. And what's really interesting when we think about this is that if I can just get your attention to my left, to your right, you'll see that a whole number of the tests that we have currently differentiated between the diagnostics and the screening tools actually checkmark no. So there's just, even if you didn't read all the criteria, it says something in terms of what's out there currently. I've highlighted the two tests that I'm going to spend a little bit more talking about, but you can again see when they talk about, to the far right of the first chart, adaptations for individuals from culturally and linguistically diverse communities, there's very little that's noted within the context of each of these tools. You may be familiar with some of them. One that's commonly used from a screening perspective, sort of sitting between a level 1 and a 2, is the MCHAT. Diagnostically, the ADOS is something that you may be familiar with, or it stands for the Autism Diagnostic Observation Schedule. But it just highlights to us, based on a survey that was done 5 years ago, that when they look at adaptation, specifically to tests, this is what we find, that there isn't a lot of energy put towards that. Now, what's happening as we speak is that there's a big shift in terms of taking these tools and applying them across other contexts outside of the Western context, and then there is more work happening at adaptation, but that raises an interesting question as well, which I'll get to in a second. So I just want to highlight that here, and that many of these scales actually span the adult, sort of from the pediatric into the adult age group. The challenge that I think we need to think about is our ability to move beyond translation. Because I think our initial reaction is, let's take a tool that's been developed and just translate it, right? That seems to be the easy thing. And often our initial cultural consideration in these contexts is language. But what I want to highlight is that, language implies a certain level of understanding. And so the population to which the tool is going to be, translated into, what is their understanding of the language that's being used, number one. Are there incongruities that exist in the conceptualization? I've always been fascinated that even the concept of autism, or autism as a diagnosis, doesn't actually exist in most languages. So that's an important consideration for us to think about. So when we're translating concepts like social communication and so on and so forth, what does that mean? And then this final piece around cultural adaptation versus cultural consideration, or some mix in between those two. And so let me elaborate a little bit about that. There has been some work that talks about content adaptation, and some work that, and some work that talks about process adaptation. Content adaptation is really a deeper structural change, as this particular quote highlights, to address those core values, competence, beliefs, and norms that match both the investigator and the targeted participants. That's something much deeper than just taking something at surface value, at a surface level, such as from a process perspective, when we might think about minor modifications such as literal language translation. So what I want to challenge us is that although we might be administering or utilizing or recognizing folks that emphasize language, there's something broader than this that we have to be thinking about, particularly as we consider the development of our tools. And interestingly, the guidelines that define translation stem back to 1993, right? So there's a lot that's happened since that time. And what you'll see is a particular process that's outlined within the literature that emphasizes certain steps. So the translation, a back translation, review, pretest. So people have obviously thought about this, but at a language level. And so what I want to consider us to think about more broadly is, what is the consideration of all those other cultural experiences, variance, and diversity when we think about the development of our tools, and then their application eventually? And so the Harris paper, going back to it, actually makes a number of recommendations for us to think about. They talk about, what is the role of diversity as it comes to standardization processes, right? In which particular population were particular tests and tools normed, so that's an important consideration. We've talked about this notion of ESL, or English language learners, and their involvement in those tools, right? Particularly from a development perspective. That piece about considering family and providers, right? I think that where I want to take this conversation next, and hopefully I have a little bit of time left, is to think about moving beyond just the child when it comes to our assessment tools and our screening criteria and our screening assessments, and thinking about observations of these kids not just in silo but across their various settings, right? We're fortunate enough to have kids spend time at home in clinical settings and schools and other environments, so being able to capture that data across environments can be particularly helpful, and this is one of the strong recommendations that comes out of the Harris paper, and ultimately emphasizing function, right? And again, we'll talk about this in a slide or two, but this notion of what is all the information that we're collecting, how is all the information that we're collecting allowing us to understand what that child's functioning is? So not what the areas of deficits are, because that's where the biomedical model thinks about, but what are the areas of functioning, and how can we then further support that functioning across sector, across environment? And keeping in mind that individuals who are moving do have an acculturation process that happens as a result of movement that can take time, and things can shift, right? So you can assess kid at day one, assess them 2 years later, things can change by virtue of cultural components, but also just the evolution of that particular kid with regards to their growth process. I won't spend much time on this particular slide, but just want to highlight that what's happening here is really one particular study group using a particular framework to emphasize criteria, again going back to that cultural adaptation piece, right? So what I'm trying to think is that how do we move away from that if we have to, and then what does that mean for the tools that we develop? And you're welcome to look up this reference later on. So I said I'd come back to the MChat, a modified checklist for autism and toddlers. There is a revised version as well that's been developed more recently and has been studied. It's certainly one of the more common tools that you might hear about when it comes to screening from an autism perspective. There's a number of critical items that are involved as part of the test that, you know, if you score on enough critical items, that raises the flag from an ASD perspective, requiring further evaluation. And that's when somebody might eventually make their way over to a diagnosing professional. That can vary. But some of the considerations that are reported in the literature as challenges or areas to identify and address are simple recognition of yes-no constructs. As a simple example, we may not think about this because that's something that may be common to us, but this whole notion of what is a simple commitment to yes-no versus more of a qualitative description of a child's behavior. So the MChat is very much a yes-no question. I actually did it last night on just to sort of check off what those items look like, and it does sort of force you to ignore variation, or that in one environment a child might do something, but in another child they might not. At the same time, there are variations and versions of the MChat that have been developed across different populations. I've summarized some of them over here in different contexts, but some of the considerations are, you know, how do we understand interest in other children when it may be interpreted potentially culturally as shyness or modesty, right? So there is, again, a little bit of that disconnect in terms of the language that we're using on our tools and what families might interpret it. Within the Mexican Spanish culture, from my review of the literature, peekaboo isn't noted as a particular game. And so it's more of a description rather than it having a concrete name. And so how do we capture that when we think about our assessment tools? What are more culturally relevant toys that somebody might be familiar with across different home environments? And what does that mean for that particular child's interaction with those specific toys? The other thing that I want to highlight is that there are other tools. So awesome. So I've got 5 minutes to cover, I don't know how many more slides, but a few more. So the translation of social communication questionnaire, which is again another tool that's been used clinically to identify areas of social communication development. And you'll see here that even within that, there's room for, is something or some behavior a social behavior? Is it a communicative behavior? Does that flip on itself in other settings for, you know, from an interaction perspective? So there's a lot of nuance to those specific interpretations that may exist. A more recent tool, if you skip to point 3 here, that's been developed out of Sri Lanka is the Pictorial Autism Assessment Schedule. And that again starts to use pictures as part of some of the descriptions that it might be using. So people are trying to think creatively about what this means and again how this might be interpreted. But again, I go back in terms of what populations are used to help develop these tools and what does it mean for their application. So a few more slides, but you know, the one piece that I was struck by, and I think this is another challenge that we have as researchers and folks that think about this, is that, well, it's great if you have culturally appropriate and relevant considered screening tools, but what about the diagnostic tools, right? So how do we bridge that particular space? And I think that's another important consideration. So it's not just thinking about each of these elements from an assessment perspective in isolation, but rather an integrated whole. Again, you know, there is, from a language perspective, there have been some more standards that have been set as it relates to, you know, how do we limit or minimize the risks that may exist from a linguistic, psychosocial, cultural perspective when we're developing tools or back translating them, for instance. And so again, it just highlights that people are still in 2019 now thinking about this. Okay, so barriers. I've alluded to this. I won't go over this in a lot of detail. There's lots of elements that can affect our ability to engage with some of these translated tools that exist, and that sets up a whole other set of challenges. What I want to spend some time is in the last few minutes is really just highlighting how do we think differently. And again, I've said there's lots more questions than answers, but I do want us to think a little bit differently. I've alluded to some of these concepts already when we're identifying, and many of us are doing this in practice, from a strength perspective, from an ability perspective, from a challenge perspective, but how do we bridge these two? And the natural shift that's happening and conversations are starting to emerge that many of these other papers referenced are really thinking about ecological frameworks, where we're thinking about the whole unit, right? The child, the family, their community, and making sure that our best possible information is not just coming from a respondent, although that's important, but rather a combination of respondents, to allow us across different settings to understand what this child is, that then takes into consideration from an assessment perspective our ability to identify what some of those cultural nuances and variations might be for the child that we're seeing and how that might help target some of our assessment. Just as a couple of quick examples, the functional abilities classification tool is one that's been developed by some of my colleagues at McMaster, as well as the autism system of classification and functioning. So these are a couple of tools that are just helping to shift the conversation in terms of how do we capture, yes, there's the diagnostic piece, and obviously we have to think about that within the scope of autism spectrum disorder. That's what we're doing here today. But there are broader conversations that are happening that are shifting our understanding to more dynamic assessments, recognizing that children aren't static, they can change, they can evolve over time, and that may then guide our ability to intervene, appreciate, recognize where we might be able to play a role for that particular child or family. I will skip this, but it's something that you can look over. I'm at 1 minute. So best possible collaborations, my final slide. Really what I just want to highlight, and again for us to think about, is that this comes from some work that was done around dynamic assessments, which I've been particularly more interested in recently, which says that the assessor shows curiosity in and respect of the plurality of views, ideas from different actors. Strive for creating a collaborative network to help the pupil. This is obviously coming from the education sector, but we can really think about it across other sectors as well. And then finally, assessment is teamwork. At the end of the day, barriers to learning may actually originate in the behavior attitudes of peoples involved in teaching and learning. There can be barriers between different professions, paradigms that need to be overcome. And what I want us to challenge is to go back to our respective settings, think about what those barriers might look like as it comes to the process of assessment, whether screening, diagnostic level, intake assessments, what have you, and how we can help bridge some of that together. So, on that note, I will put up my talking points again, my takeaway points, and open it up for any questions. Thank you. The question, everybody hear the question or no? It really is a question about, while we try to answer some of these questions that I've raised, what are some practical things that we can be doing in clinical settings as diagnosing professionals? I think one is a sort of adaptation on the spot, which is often asking families, is this something that your child's been exposed to, right? So something as simple as that. I think not assuming that every child has had the same experience in terms of exposures. We often talk about birthday parties as one example. That may not be the case for everybody, right? Or really pushing that question forward as when you get to a particular press or item within an assessment, asking that. I think, one of the things that I've often struggled with also is how do we get into the space where we are having families come with interpreters and there's lots of conversation that's happening between families and an interpreter, and then you get back a single line, right? And so there's a lot that's happened in there, but how do we get into that space? I think, again, it's being explicit with families is that are there any specific considerations we need to take into account, and who can we ask information to, right? I think one of the things that I've learned being in my setting currently is that because kids have so many touch points, I think giving the opportunity to families to be able to collect data from those multiple touch points really does empower them and brings back a more holistic picture of that particular child. I think sometimes because of time and limitations or language barriers for that matter as a simple consideration, that can be challenging or tricky, but really giving the opportunity, if you are going to give out a questionnaire, maybe helping to identify that, who are the key players that can help answer that question and not sort of just throwing it out there and saying, I want it from this person. So that's another consideration within that space. The reality is that many times because of these issues, we may not give out the questionnaire, right? And I think that's the issue is that if you're going to get back a questionnaire where there's only been so many responses, a lot have been left blank. There's an issue there, right, that we need to think about. And either then exploring those questions in person with the family is an opportunity, or thinking about other tools, right, that we may have to think more broadly about.
Excellent talk, thank you.
Thank you.
It reminds, I'm in treatment, autism treatment, not on the diagnostic end. And I remember I was working in a center in Massachusetts, and we had a young family from Japan come with a 13-year-old boy, and we were teaching her to reinforce eye contact. On the fourth day of this program, the mother wasn't doing what we were asking her to do, but she was clearly intelligent. She wanted to be there. She wanted to help her son. So I pulled her aside and asked her, what's going on? Why aren't you following kind of what we're asking to do? And she very almost, I'm going to say shyly, expressed her thanks for our work and said, the last thing I want is for my child to go back to Japan and look in people's eyes directly in the way you're asking us to do, because he'll stand out even more. And it was a real eye-opener for our team, and we had to have this kind of conversation. So I just wanted to say that I think on the treatment side, what you're saying is very, very relevant for us as well. And I had a question, which is there sometimes overdiagnosis as well? So for example, this young boy in America with the lack of eye contact would get that low eye contact, but culturally he was, according to his mom, maybe within the norms. Thank you.
Yeah, no, thank you. I think there's a real risk or consideration that needs to be given in terms of where some of those parameters are drawn, and it goes back to those broader questions around criteria and what those mean from a diagnostic perspective. So there is, definitely consideration of what practices look like from an overdiagnosis perspective. There have been some recent papers that have come out that are sort of starting to raise some of those questions, and it does clinically ask, right, like where do you draw some of those lines, for the lack of a better word, in terms of identification. And I think it's an area that I think as we move forward, many folks are studying it not just from a functional brain imaging perspective about, how do two brains of individuals with or without ASD or any other developmental issue look similar or different, and what does that mean from our clinical practice level? And I think in the next 5 or 10 years, and hopefully in the next 2 days, we'll be hearing variations of that from some of the other speakers that are lined up. So, great. Thank you.